Thank you, everyone, for staying around to attend this last keynote session, which I promise you will be very thought-provoking. We're very excited today to have two speakers and a discussant. We'll be starting with Dr. Denese Shervington, who is the president and CEO of the Institute of Women and Ethnic Studies in New Orleans. She directs a community-based post-disaster mental health and emotional resiliency recovery program and federally funded trauma-informed teenage pregnancy prevention program. And she's also the clinical professor of psychiatry at Tulane University. Following Dr. Shervington's talk, we'll be hearing from Counselor Jackie Dyer, who's a member of the founding team of Black Thrive and chair of the Black Thrive Steering Committee. She's recently been as vice chair of NHS England's Mental Health Task Force, led the 5-year forward view for mental health strategy, and we all know how important that is. And finally, we'll have some closing thoughts from Dr. Reiki Shaw, who will be touching on some of the points that she brought up this morning, who is, again, a pediatric registrar and working with the Association for Young People's Health. And following the discussion, we'll open up for questions. So without further ado, Dr. Shervington.
Can you hear me? Great. It is indeed an honor for me to be here in multiple ways. To be invited to speak makes me feel as if I'm rising up the ladder, that my work is pretty okay. Dr. Hatch, as you know, has very high standards. And also hearing the presentations all day has made me feel like maybe I've arrived in the club. So I thank you very much. And it's also somewhat bittersweet always for me being in London, being a Jamaican, whatever that means. And it's good to hear the voice, the Jamaican voice when I'm here, because I usually don't hear that in the United States, because I'm not living in Brooklyn. I'm in New Orleans. And then my third thing is I am going to make a public apology to my daughter and communications director. She thinks that the visual quality of my slides don't hit the bar. I told her maybe you'll all look at my dress instead. I think it's pretty colorful. But it is really an honor for me to share with you some lessons we've learned in a post-disaster environment in New Orleans. And you might think there are no disasters recently, acute disasters that have happened here. But I ask you to think about the chronic adversity that some of your population experience. And this is really what you will see. And I feel very affirmed in making the statement from the earlier presentations this morning about the conditions for young people, especially those living in poverty, those who are of color, and those who might be LGBTQ. Or, I love this term, those who are carers. We don't use that as much in the US context, but definitely it's going to creep into ours. So first, I'm going to be talking about children. And if I want to say what we've learned in New Orleans is, as you look at trauma in young people, you cannot take a simple linear approach, especially in New Orleans after a major acute disaster, which made it very easy to make diagnosis of post-traumatic stress disorders. Suddenly, I began to learn that this is a much more complex picture than the diagnosis gives. And so I'll talk a little bit about that. And also why it's important to take a more complex approach to looking at adversity in children. As the point was made this morning, they don't have the autonomy or the knowledge of how to remove themselves from the adversities oftentimes in which they're living. Maybe when they're 12 or 13, they might run away from home, and then we have a whole different set of problems. And so it behooves us to look at the complexity of the experiences that they're having and trying to come at it in this way. And ultimately, if you take anything from my talk, is that we need to love our children, and we need to love all our children, because we could solve a lot of the problems. We wouldn't even have to have research if we felt all kids deserved to be loved, cared for, and have access to resources. So for the young woman of Jamaican heritage this morning who mentioned, can we look at the people's ideology that create the inequities? I want to thank you for, I feel now that some of the intergenerational work is happening, that a young person could take on this view. So and this comes from an Englishman, analyst and internist, John Bowlby, who talked about children's need for attachment. Up until this point, Sigmund Freud, from your all cousins or whatever, he was here for a while, had cut out of his original thinking the idea of trauma, external trauma, as impacting young people, and began to see mental health problems only as inner drives and conflicts. And so someone like John Bowlby, and later on Winnicott, some of those analysts began to say children are in relationships with other people. There's an interpersonal realm to their struggles, and we need to think about trauma in this way. And the most important thing is that for children to grow and thrive, they need to have affectional bonds with their caretakers. They need to be held, they need to be mirrored, their beauty, and they need to be facilitated in believing that they are of value. And if we are able to accomplish that, especially in the first 3 years of children's lives, some of the challenges we're seeing now would diminish. But we have not created societies that are just and that support these kinds of child-rearing practices in many spaces. So just want to put us on even playing ground. Trauma has become so overused now, the term, that I'm worried that people are going to stop talking about trauma in another generation, because everything now is about trauma. But really, everything is about trauma. And simply, it's just an overwhelming experience that makes someone feel that they cannot cope. And oftentimes, it creates dysregulation psychologically and physiologically. So it's not the simple little everyday things that we run into and it's like, oh, this makes me feel bad. It's actually when it makes you feel that you could die. It becomes a death encounter. And I don't think this is necessary to say some of the sources of trauma, and I will talk about the big one in New Orleans that then led to undoing some of the more complex traumas that kids experience. As you probably know, natural disasters, military combats, rapes, severe car accidents, and some of the more chronic experiences, especially at the interpersonal level, the adverse childhood experiences that now I think has also crept into most people's communications, domestic violence, homelessness, as was presented on earlier today, is a source of trauma in people's lives. Severe chronic illnesses, and important in many urban settings, community violence. And I'm going to assume everyone in the audience has some working understanding of the adverse childhood experiences. Great. So basically, it's before the age of 18 years, any kind of abuse that a child experiences, physical, emotional, sexual neglect, or household dysfunction. And again, we this morning was paying attention to a lot of emphasis on how the familial and social experiences that people are having, and particularly when it creeps in the household, can create challenges for young people. Very important in the US, and my sense here also, is the impact of parental imprisonment on children. We sometimes forget this is an extreme loss, huge separation and attachment issues. And in a group that I was asked a couple of years ago of young girls, they were having problems managing and they were in the 3rd grade, so they were about 10. They were about age 10. Every one of those young girls, and there were 12 of them, had a parent who was incarcerated. And a lot of their sense of loss and abandonment had to do with that. Added to the age, a group in Philadelphia decided that the conventional adverse childhood experiences survey, which really was initially done or was done in a very middle-class white population, was not fully capturing the experiences of all Americans, in particular those in urban settings. So they went ahead and expanded the ACEs, and this is now called the Philadelphia ACE, to address community traumas. So witnessing violence, experiencing racism, living in unsafe neighborhoods, experiencing bullying, lived in foster care are some of the items they've added to address chronic childhood traumas. Would people say that this is somewhat similar in this environment?
Yes.
Okay, thank you. So the work began for us at the Institute of Women and Ethnic Studies. We're a community-based public health organization. This work really began after Hurricane Katrina happened 13 years ago. It was, up till recently, the most severe hurricane in US history over the past 8 decades. The city was basically destroyed, and for those who suffered most, the majority, they were, as you can imagine, African Americans. And the more poverty you lived in, the more you were likely to suffer. Over 500,000 of the residents had to evacuate, and those who had the most difficulty returning home and who were labeled as other than what they were, internally displaced people, referred to as refugees, sometimes criminals and looters, were African Americans. They say over 1,800 was killed, but kind of what happened in Puerto Rico when you saw the jump in Puerto Rico from 65 to close to 4,000, we probably hit about 10,000 lives in New Orleans. And that was shared with me by people who work in the death care industry. So what that meant was, as we developed a division of post-disaster recovery, and now we're not the public, unlike what probably would have happened here, your public authorities, the universities, and the health system would have collected data. That did not happen in New Orleans, and we say that it's because our mental health infrastructure was severely destroyed. That's debatable. It might have had more to do with the leadership for many years. So our organization took on the task in 2010 to begin to screen young people that we were seeing for evidence of trauma-based disorders, which meant looking at the rates of depression, PTSD, domestic violence, and because we knew that this was important, the other exposures they had to violence and some of the things they worried about. And what you can see here, the most important thing on this slide is that perhaps these numbers should be 0. People always ask them, what's the acceptable rate of depression in children? I said 0. Why should children be depressed? What's the acceptable rates of PTSD? PTSD is very treatable. We cannot avoid traumas from happening, but if we treat them, the person will be healed. The majority of people will be healed, and we can get this back to baseline. We saw that happen in New York after 9/11. The PTSD rates doubled. Within 6 months, they were back to normal. Well, what happened in New Orleans, because we did not have the kind of psychosocial supports we needed, PTSD rates have remained elevated still 13 years later, and they're about 2 to 3 times the national rate, and I would say they're above what it should be, which should be 0. And we find here the most important thing on this slide is that young people who are exposed to violence in their homes or violence in the communities, and those who worry about not being cared for, not their basic needs not being attended to, are more likely to have adverse mental health outcomes, post-traumatic stress, and depression. And it was when I started thinking about this last category, why are kids worrying about not being loved, not being cared for? And I began to think maybe just the diagnosis of PTSD alone is not sufficient. I mentioned having to do a group with some young people. I'm not looking my best right there. And I went to go do a 6-month treatment course with them for PTSD. So I took CBITS, and we talk about cognitive behavioral interventions. And I was all ready. I was prepared. I knew what, it's very scripted what should happen. And within one session with the young people, I realized I can't do this. This is something different is happening here. This is not just PTSD. And we screened them, and they had PTSD and they had depression. But spending time with them, I realized that what they were really struggling with was feeling attached and loved and cared for. Because what they would do, that I had to ask the principal for permission. When I went to do the group, they would want to come close to me. They would want to, at that time I had hair, they would want to play in it. And I'm going, there's something else happening here. And sure enough, there is. And also, about 2 weeks ago, I was in one of our meetings told about our organization being asked to do a special group with some young girls. These are 4th graders who are acting out, in air quotes, because I don't like that term. They're behaviorally dysregulated in the classroom. And so I asked the social worker, I asked her, would you do one of our screeners, which is to check for trauma-based disorders? Because usually in the classroom, what the teachers see, just people cutting up. That's the term they use. Kids are cutting up in the classrooms. And sure enough, so this is just a sample of 9, but it just tells the story again. When we screened the young people, 7 of the 9 were positive for PTSD. 6 had depressive symptoms, and it's really hard to get depression in children because sometimes they don't have the language. I usually pick up depression after I've been with a child for more than one, certainly not on a survey. It takes them a little while to understand that those are the symptoms they're having. But at least 6 of them had significant depressive symptoms, and 1 actually had clinical depression. 4 of the 9 kids were exposed to domestic violence. 2 had witnessed murder. I don't think I saw a dead body until I was in med school and in the cadaver lab. But so can you imagine for a child seeing dead bodies? My cadaver partner never came back to the lab for about 6 classes. It took him a while. And the kids, again, are worrying about violence in their lives, and they're worried about being loved at home. So it's easy to diagnose PTSD. We have the criteria. It's when you've been exposed to some event that makes you think that you could die, or there's violence, or sexual violence. You've seen it, you've witnessed it happening to someone else. You learn that it happened to someone who's close to you, or you're a first responder. And then a series of things happen a month later. You have intrusion symptoms. You can't get it out of your mind. You're having flashbacks. You're also trying to avoid any memories of the experience. You begin to feel badly. You begin to have bad thoughts about yourself and the world. And very important, in children, they become hyper-aroused and very reactive, on edge, startle easily. And for many, they begin to dissociate. And depression. I'm going to skip that. The challenge we have with the diagnosis, which I've made and will continue to make, but in children, is that it does not fully capture the impact of chronic adversity. Because when children are experiencing chronic adversity, well, let me step back a little bit. So what usually happens, these kids, especially if they are poor or of color, are more likely to get a diagnosis of a behavioral disorder like a conduct disorder, an oppositional disorder, which basically means they're bad. And they also are diagnosed with attention deficit disorder, which means that there's something going on in their brain, and you're going to give them amphetamines to make them calm down. That's what we do with ADHD. So what you'll always find for our kids, they're getting these multiplicity. If they're lucky, they'll get a diagnosis of PTSD, which makes it a little bit more, you feel a little better about that, less stigmatizing for the child. But, you know, trauma, okay, Bessel van der Kolk and some of his colleagues began to say we need to take a more developmental perspective when we look at young people and address them as the whole. Because what happens, especially when there's disruption in the attachment or the interaction, the affectional bond with a caretaker, they're going to get dysregulated in multiple ways. They're going to have problems regulating their emotions, they're going to have problems with their attention, and they're going to have problems relating to other people and also their own sense of themselves and their identity. Because basically they are not able to modulate their internal states, how they're feeling. And many also, and I've seen this in so many kids, are having dissociative experiences where they're kind of disconnecting from the reality of themselves, the world around them, or even that they experienced this trauma. So what we did several years ago was do a study which we call the Wellness Evaluation Community Action Network, where we ask community, what do you think are the indicators of well-being for young people? And Dr. Richardson, who spearheaded the study, is here. If anyone has questions, ask her later, not me. And it was, what we did, we had youth participatory action research component, where for a year, young people learned research methods and worked with us to define what the criteria were. I think earlier we heard about young people prioritizing what's important to them. We did focus groups with people who work with kids, and then from local and international, Dr. Hatch was one of those experts. We developed consensus about what was important to young people in terms of their wellness. And the three priority areas were their basic needs, having supportive adults, and their emotional well-being, which basically means, again, goes back to the issue of caretaker attachment and positive bonds. So we began a second study, which is where I got the data from those 9 kids, where we're looking at doing a school-based intervention where we're trying to impact young people's emotional well-being through looking at attachment. So we've introduced attachment-based play to change the school culture. In New Orleans, our schools for poor children are like little prisons. They are they're very punitive. They can't speak at lunchtime. I've observed a class where the kindergartners could not speak during lunchtime. They have to track teachers' eyes. They have to walk on straight lines. So we're trying to change that. Going back to the inequity and the ideology, all children should be almost in Montessori-like school environments. Why should poor people be in prison-like environments? It became that basic to us. And so what we've done, we've introduced attachment-based play, trying to change the interaction between teachers and the students. We want to help create structure for the kids, do positive engagement, be more nurturing, and at the same time challenging them to be the highest, to develop and thrive to the highest capacity that they're capable. And just in closing, why this study perhaps is one of the most important ones to me. One, I want to change all the school environments that poor children find themselves in. And because I feel that based on what we know about development, when children are behaviorally dysregulated, which is usually how they're seen, it's because of the complexity of their emotional challenges. And to use our hashtag in our campaign in New Orleans, they're sad, not bad. And what they need is to be away from the trauma-related triggers. Oftentimes, as I just shared, the schools themselves are as traumatizing as the homes and communities that they're coming from. We need to help them to not so quickly resort to being in flight or fight mode, which is what happens in a child who has experienced chronic adversity. And we need to help to create just pleasure and joy in their lives. At the same time, they can also learn. And so this study is trying, just share a little bit, I'm sorry, I know my time is done. The Public Will campaign that I barely mentioned in terms of hashtag sad not bad was to remind people in New Orleans that our children need psychological intervention and not to be put in the criminal justice system, which is usually where they are. And we are in the midst of that Public Will campaign. And basically, music is really important in New Orleans. Children love to be in school and marching bands. So this, to me, is a happy child. And this is what we want for all children with whom we work. So thank you very much.
I suggest that we take one or two questions before moving on to Counselor Dyer.
I hope the slides were tolerable. You all good? Okay.
Hi, Dr. Shervington. Thank you for a brilliant presentation and mentioning Bessel van der Kolk, who I think is essential reading for anyone interested in trauma. I work for a charity called Youth Access, but I'm speaking in a personal capacity. I have personal experience of PTSD from being in a house fire, so this is my big passion. We've had a series of mass traumatic events in the UK in the past couple of years, from terrorist attacks and also as a result of the Grenfell fire. I think that's really focused attention on the issue of PTSD and trauma in the UK, and rightly so. There's been an outpouring of support and pro bono support from lots of organisations to help those communities. It's gone nowhere near it far enough, but there have been some innovative ways of finding people that have been touched by PTSD, who have PTSD as a result, and they found that an enormous mass of people have been affected by these disasters. My concern is that there are so many more people that are affected by PTSD and trauma in general that haven't been involved in one of these big events that we all know about. And we know that young people in particular and marginalised groups are finding it harder and harder to access statutory mental health services in the UK. And we've got a mental health crisis for young people. So I want to hear from you and from everyone else here how we can generate the same amount of compassion and energy for everyone else that's, for the Grenfell community and the survivors of terrorist attacks, but also people who are in car accidents and who have developmental trauma, and all of the other people affected by PTSD.
So, did you want to respond to her?
No,
Okay.
I'm sorry, can we just hold off until the end? We just have this one question, and then I'd like to move on to Counselor Dyer, if that's okay, but we'll come back around in the question and answer.
So, you know what in order to get the public will and support, first one has to realize that there's a problem, and unfortunately people only respond to data. So is there some way to collect some data about the level of PTSD? And that's the simplest one to start with. And then I found what we have also had to do is to have people who come in contact with children, which are usually teachers and youth serving organizations, help them to recognize the signs and symptoms of trauma-based disorders. And then you have to be ready to do something about it, because you can't just tell people they have PTSD and walk away. And so I find, though, that those first two stages of the realizing that the problem is there and helping people to recognize, because what happens to children, they get misdiagnosed. I have done a lot of re-diagnosing of children in New Orleans. And I would think one of the great accomplishments of my career has been to get the Public Mental Health Authority to write a policy now, how much it's being practiced, that before a child can be diagnosed with a behavioral disorder or ADHD, that they have to rule out PTSD. So I think, it took us like 13 years to get here, so it doesn't happen quickly, but I think if the will is there in yourself or an organization to do this, you can see some positive turnarounds.